All right, let's shift gears a little bit and talk about rectal cancer. In my opinion, went from a very sort of stodgy, everybody had to be treated the same way, to what I now think of as the Wild West. Everybody's got their own idea of how to manage rectal cancer now. There is some evidence to support what we're doing, but a lot of people are making moves without a lot of evidence, and I really want to spend some time with you guys, much smarter than I am about this subject, to talk about that data. Gabby, let me pick on you first and kind of set the stage for us. Where are we today? Would you say there's a standard of care today for the management of rectal cancer? And let's make it T3 and node positive rectal cancers.
Yes, so I think that among all the colorectal, plethora of tumors that arise from right to left and to the bottom of it, rectal cancer is among the most controversial because we talk even among our peers, and every institution sometimes has a little bit of a different practice. Having said that, I believe that still a standard, so to speak, of care in the United States today is to do the chemotherapy with radiation for the 5.5 weeks, followed by surgery, followed by adjuvant therapy. Now again, this has been the same for the last 15, 20 years, and all we've really accomplished with neoadjuvant chemoradiation is reducing the chance of local recurrence. And we are doing currently quite a bit of research to try to shift the paradigm. Does everybody need radiation? Can we implement chemotherapy sooner to reduce distant metastases and improve survival? So there are a lot of questions that we're trying to address in different clinical trials. But I wouldn't say that we have changed really the tradition of neoadjuvant chemoradiation surgery and adjuvant at this point.
So we don't have anything new that you know of that's really shifting that to where that's no longer correct, at least as one of the options.
We have a lot of clinical trials that I think we're trying to answer questions whether can we substitute radiation with chemotherapy and improve survival? Can we potentially even not do surgery for certain patients that have amazing responses? We still haven't addressed the question, are we over-treating many patients with adjuvant therapy? But I don't think that overall we have changed standard of practice.
Yeah, I'd come back, if we dial back even 10 years or more, isn't it the British who sort of invented the mesorectal excision? And radiation to me has always been, well, I'm making up for bad, quote unquote, bad surgery. And so if I'm now doing a mesorectal excision, Marwan, does that mean I need any radiation, whether, even as a primary therapy? And the British, I think, where they of course try to trim every budget they can trim, they don't do a lot of radiation there because their surgeons say we did a better job. What's your take on that? Because our US surgeons are all doing mesorectal excisions too.
Right, we are, but I mean, but even when you look at the British data, I mean, and you look at some of the studies, clearly some of the tumors that are close to the circumferential margin that are threatening the margin of the outside margin of the mesorectum, those have a high risk of recurrence, and you're more likely to have a positive margin even with a total mesorectal excision. I think what we have not moved forward in the field is really individualizing who needs radiation. There's clearly a subgroup of patients who will need radiation where we're going to see some decrease in local relapse even with a TME, especially these distal tumors where even with a standard total mesorectal excision, you may still have a close radial margin. So until we standardize a way where we can prognosticate or predict who's going to relapse more, unfortunately, I think we're stuck with radiation for now, even though it doesn't clearly move the overall survival much. For the higher up rectal cancers, I think the local relapse rate is so low, or if you have a good MRI where you know that it's an early T3, I think it's fair to have a very good discussion with the patient and say your benefit may not be that significant based on the studies, and to consider sometimes foregoing radiation. I don't think it's a one-size-fits-all.
Yeah, Bert, let me kind of pick on you for a second. So, we've got this trimodality therapy of chemo, radiation, surgery. and we do okay, right? Our survival's not great, but they're okay. Where I see this science really pushing us is to try and minimize the post-treatment morbidity. Maybe talk a little bit about how you discuss with a patient, what are the consequences of pelvic radiation? What's the consequences of a rectal resection, on your bowel function, and just your quality of life. We're glad you're not dead, but what's your quality of life like after a traditional rectal cancer treatment?
Sure. Well, this is a very complex discussion, and obviously depends on things like, are they going to have an APR? Are they going to have a low anterior resection? It is very important to discuss potential long-term radiation complications, pelvic insufficiency fractures, urinary problems, long-term incontinence issues.
Well, I've been thinking lately too with the younger people and their more commonly distal tumors that you have fertility issues for women that come into play now.
Absolutely, absolutely. And then obviously the major fear of all patients is to be left with a colostomy permanently.
They don't like that, do they?
They don't like that idea, even when the alternative is to have a high risk of recurrence. Many patients are resistant to that.
Well, or 10 bowel movements a day. I mean, that's sort of the trade-off sometimes, is the very frequent bowel movements and knowing where every Starbucks restaurant is that you can use. Wells, what are your thoughts on this?
I agree, and I just to tie back to your discussion of fertility, at least our radiation oncologists don't recommend delivering a baby or even carrying a baby to a radiated uterus and afterwards, exactly. And we often have to do a surgery to move the ovaries out of the way. So as this becomes more common in younger people, I think the issues become even more acute. There's also long-term sexual dysfunction that can be a uncomfortable topic for people, but really needs to be brought up. So, and luckily we have this prospect trial that's being done across the United States that's enrolling well. And certainly we appreciate all the participation of the community sites in that. That'll be looking at if you give chemotherapy and you have a good response, can you forego radiation? So I look forward to seeing the results of that. And we've been putting patients on that study.